Welcome to today's webinar by the Paediatric Renal Nutrition Task Force, hosted by VitaFlow, titled Energy and Protein Requirements in Children with CKD 2 to 5 and on Dialysis. My name is Lucy Evans and I work as a Global Marketing Manager at VitaFlow International Limited. I'm also a dietitian by background. This webinar is the second in a series from the Paediatric Renal Nutrition Task Force, which will run throughout 2021. The paper which is referred to in today's session is published in Paediatric Nephrology. A link to this paper has been posted in the chat box for you to access. A link to the paper can also be found on both the VitaFlow VIA website and the European Society of Paediatric Nephrology, or ESPN, website. The paper is available via open access. This webinar is intended for healthcare professionals only. The webinar will last approximately 1 hour and 30 minutes, which will include dedicated time for a question and answer session in the last part of the webinar. If you would like to ask a question, please use the question feature on your GoToWebinar toolbar. All questions will be screened, with as many questions as possible being answered by the speakers at the end of the presentation. A practical guide and case study will be discussed during the webinar. You will find the practical guide in the handout section on the toolbar. This can be downloaded for you to use. You can also access your certificate of attendance here. The webinar is being recorded and will be available on the VitaFlow VIA website in approximately 2 weeks' time. The views herein are of the presenters and do not necessarily represent VitaFlow's views. The material herein is accurate and as of the date presented and is for educational purposes only and not intended as a substitute for medical advice. You will see the learning outcomes for the session, which are documented on this slide. So, without further delay, let me introduce our speakers for today's session. VitaFlow is delighted to introduce Dr. Michiel Oosterveld, Vanessa Shaw and Nonnie Polderman. We are also joined today by Dr. Rukhsana Shroff, who will provide a brief introduction to the work of the task force, and Dr. Shroff will also be chairing the question and answer session. Now, I know that many of you are aware of the work of Dr. Shroff. So Dr. Shroff is a consultant paediatric nephrologist at Great Ormond Street Hospital in the UK. Her research focuses on bone and cardiovascular disease in childhood CKD and improving outcomes for children on dialysis. Rukhsana is the co-chair of the Paediatric Renal Nutrition Task Force. So I'll now pass over to Rukhsana to start the webinar presentation.
Thank you very much, Lucy, and welcome everyone from my side as well. So approximately 3.5 years ago, we as a team of members from 8 different countries around Europe and North America put together the Paediatric Renal Nutrition Task Force. Our aim was to improve nutrition in children with CKD, but the real driving force behind this was the knowledge that there are several challenges faced by people in managing nutrition. There's very little that we are taught in medical school about it around the world, and that many specialist pediatric centers do not have renal dietitians to support them. As you see here, we are from 8 different countries with doctors and dietitians, and our group is endorsed by both the European Society for Pediatric Nephrology and the International Pediatric Nephrology Association. Our vision is to ensure best practice in the nutritional management of children with chronic kidney disease and other renal diseases, including those with kidney transplant as well. Our mission is to formulate practice recommendations to enable best clinical practice, to provide education and training resources for healthcare professionals who care for children with kidney diseases, to devise resources which will help and offer practical support, and you will see a lot of this in the course of our talk today. And the support is for children and their families as well as for healthcare professionals. And finally, we want to promote research and expand the evidence base for nutritional intervention in pediatric kidney diseases. In the last 4 years, we as a group have developed about 6 different guidelines, as you see here, ranging from the assessment of nutritional status, energy and protein requirements, the dietary management of calcium and phosphate, the management of potassium, the delivery of a nutritional prescription by enteral tube feeding, And most recently, we've submitted a guideline on obesity and metabolic syndrome, and we are working on one on the nutritional management of AKI. All of our guidelines are published in Pediatric Nephrology, all as open access. And as Lucy said, you can access them on the web or through the ESPN or the VitaFlow website. We also have a list of webinars here, and we aim to continue these presentations so that you have an opportunity to implement the guidelines alongside us publishing them. So let us move on now, and I'd like to introduce Dr. Michiel Oosterveld. Michiel studied in Groningen and trained as a pediatrician in Amsterdam in the Netherlands. He's also had pediatric nephrology training in London and Utrecht. He's obtained a PhD and his thesis being the measurement of protein metabolism in critically ill children. He's now a consultant in the eminent Emma Children's Hospital in Amsterdam and the head of pediatric dialysis department, and indeed even the Dutch Association of Pediatric Nephrology. His research focuses on primary hyperoxaluria and nutrition in children on dialysis. So Michiel, over to you, and thank you for joining us today.
Thank you, Roxana. Thank you for those kind words, and thank you for asking me to join in this webinar. As previously mentioned, the subject of our talk will be the clinical practice recommendations from our group as published in the Pediatric Nephrology. And so why would nutrition be important for children with CKD? Of course, because it affects growth and neurodevelopment, and especially in the infantile phase of infantiles and toddlers, the effects of insufficient nutrition can be impressive. As you might know, the energy demands of growth as a percentage of total energy requirements amount to approximately 40% in the first month of life, and then almost 18% in the next 3 months of life. So growth is a sensitive indicator of whether energy requirements are met. And if energy requirements are not met, the impressive amount of growth that is attained in the first months of life will be affected immediately. And as the body needs to attain almost half of the final height at the age of 2 years, insufficient growth in these first months, years of life will affect end height, and will cause a delay in growth that will affect or will be really hard to correct in the rest of the life of a child. But nutrition is not only important in the infantile and toddler phase, but also in the childhood and pubertal phase, when growth is more dependent on the IGF and the sex steroids. But a good nutrition will support growth even in this time and will affect the attainment of final adult height. And if nutrition is insufficient or incomplete, might affect body composition and even developmental delay. So we, when starting on this project on protein and energy requirements in children with CKD, there was this publication of the National Kidney Foundation Kidney Disease Outcome Quality Initiative from 2009, which were the clinical practice guidelines for nutrition in children with CKD, that were an update of the 2000 National Kidney Foundation KDOQI Nutrition and Chronic Renal Failure Guidelines. And the aim of the Pediatric Renal Nutrition Task Force was to provide clinical practice recommendations updated wherever there is new evidence subsequent to the publication by KDOQI. And for this purpose, we formulated the following PICO questions for our literature search. So the population was children from birth until the age of 18 years with CKD 2 until CKD stage 5D, i.e. Children on dialysis, with the intervention of nutritional requirement for energy and protein at the different stages of CKD, compared with the nutritional requirements for age-matched healthy children, with the outcome being normal growth and development with these children. Once we started the literature search, we found that prematurity and metabolic diseases were outside of the scope of our literature search. And for this literature search, we used the following terms, which were mostly any word mesh term that we could associate with our PICO question. And running this search, we found over more than 100 papers. But having applied the limitations of only including meta-analysis, systematic reviews, randomized controlled trials, and prospective studies with more than 20 children, our number of available articles came down to 37. And we only included retrospective pediatric studies unless there were no other papers to include. Following our literature search, we formulated clinical practice recommendations and graded them on the basis of the evidence found. And for this purpose, we used the grading system as published by the American Academy of Pediatrics, which has 5 different levels of evidence, level A to D, where level A is the ultimate form of evidence, being well-designed and conducted trials, meta-analyses of the applicable populations, or when regarding a diagnosis, independent gold standard studies of applicable populations, with the level D being expert opinion, case reports, and reasoning from first principle. These levels of evidence are then coupled to the benefit or harm of the subject being studied, with when either benefit or harm predominates, can yield a strong recommendation, but when evidence is of less quality, levels B, C, and D, will yield moderate recommendation or weak recommendations. And when there is no clear advantage of, when there is no clear benefit or harm, then despite the level of evidence, we can only find a weak recommendation, give a weak recommendation. And then apart from the levels A to D regarding the literature evidence, then there's also a level X, which concerns exceptional situations where validating studies cannot be performed and benefit or harm are clearly predominates. So these are the grading systems we used for our recommendations. And then the recommendations were sent to our colleagues who had agreed to judge them. And for this purpose, we used a Delphi process where we invited dietitians and pediatric nephrologists to judge our recommendations and to mark their agreement with the statements according to these judgments. We required an overall 70% consensus. We reviewed the comments that we received from 27 pediatric nephrologists and 20 pediatric renal dietitians from 22 countries. And with that and our literature study, we came to our clinical practice recommendations. And the first clinical practice recommendation is the initial prescription of energy intake should approximate that of healthy children of the same chronological age. And we rated this recommendation as a level B, a moderate recommendation, which is quite a strong recommendation. The basis of this recommendation were 4 trials where they compared resting energy expenditure or basal metabolic rate measurements by means of indirect calorimetry and comparing the dietary intake to those, comparing the energy requirements over energy expenditure measurements in healthy children and those with CKD after adjustments for lean body mass found no difference in energy expenditure between healthy children and children with CKD. This is a slide from one of these articles where you can see that the energy expenditure adjusted for lean body mass and plotted against body weight did not differ between the children with CKD and those without CKD. There have been other studies studying the same subject with 10 observational and retrospective studies where they found that dietary intake that equaled approximately 100% of energy expenditure of the healthy population resulted in acceptable growth in both conservatively managed children with CKD and children on PD. And there is one prospective trial that included 51 patients, and these patients on PD had median energy intakes of approximately 94 to 98 of energy estimated average requirement at baseline, and even lower energy intakes at 2 years of follow-up. And despite this, they showed normal growth. So apparently energy that equals the requirements of healthy children will result in adequate growth in children with CKD. And with this advice, our advice is more or less the same as the Kadoki 2009 recommendations, but we do use the word approximate to allow for individual variation of energy prescription. Okay, when we came to this conclusion that energy intake should match that of healthy individuals, we started studying the advices or the recommendations for healthy individuals. And for this, we found guidelines of multiple national and international bodies, which are mentioned here. And unfortunately, all these recommendations contain different definitions of energy intake. For instance, daily energy requirement, estimated average requirement, and estimated energy requirement. And obviously, these are more or less the same, but not absolutely the same. And also, there are quite big variations between countries. For instance, the suggested energy intake for a 2-month-old baby in the United States of America is 95 kilograms per kilogram per day, whereas in the United Kingdom, the advice would be 120 kilograms per day. Kilocalories per kilogram per day. And the same goes for protein requirements. Also, multiple national and international bodies have recommendations for protein intake in healthy children. Most of them are based on studies using nitrogen balance studies. And they come up with different definitions or requirements, and also these definitions are not all the same, and they also do not result in the same recommendations. For instance, the suggested protein intake for a 3 to 5 month old baby in the Netherlands is quite different from the French recommendation. And so we decided not to endorse any set of published values, but to take an average of the published suggested recommendations, excluding outliers, and using a range of diet, caloric, and protein intake. And for this advice, or for this recommendation, we came up with a new term being suggested dietary intake, or SDI. And assuming requirements are normally distributed, we came to the following recommendations. Our energy intake recommendation, we give a range, and the upper and lower limits of our SDI fall within the average amount of the published values, i.e. when giving energy intake, when prescribing an energy intake according to our SDI, 50% of the population will have their energy requirements met. We also decided to use the SDI for protein requirements, but we will give a range of protein intakes, but the upper and lower limits of the SDI fall within the average amount plus 2 standard deviation of the published values. That is, when prescribing protein intake according to the SDI, 97% of the population will have their protein requirements met. And thus, excuse me for that, these are the SDI for protein and energy from birth to 18 years. And birth is a birth age of at least 37 to 40 weeks of gestations. And premature infants have higher protein and energy requirements, but we decided that we could not take them into our advice, as they will have other requirements than term-born children and older children. These are the energy and protein requirements for older children over the age of 1 year. And the energy requirements or recommendations are based on the lower physical activity levels when they were presented in the common recommendations, assuming that children with CKD have low activity levels. When a child does not have a normal height, or other words, when it has a severe growth delay, it might be reasonable not to use the patient's age for estimating energy requirements, but to use the height age. And the height age is the age that corresponds to the patient's height plotted on the 50th centile on a chart. So when a child is exceptionally smaller than his peers, we should not prescribe the energy and protein requirements based on the weight, but based on the height that corresponds to the height of children that have that height as an average. So that should be taken into account. So, which brings us to the second recommendation: to promote optimal growth in those with suboptimal weight gain and linear growth, energy intake should be adjusted towards the higher end of the SDI. And here is again the height, the advice to use the height age for children with poor growth. And in overweight or obese children, adjust energy intake to achieve appropriate weight gain without compromising nutrition. As you know, apart from the corona pandemic, there is a second pandemic affecting not only us, but also children across the world, which is the obesity pandemic. These are data from 2019 from the IPPN registry, the International Pediatric Peritoneal Dialysis Network registry, showing that on average, almost 20% of children starting PD are either overweight or obese, as opposed to 9% of children who are underweight. So there are more children overweight than underweight. And also, apart from limiting energy intake to achieve appropriate weight gain, one should focus on lifestyle changes and improvement of physical activity to attain a normal weight. Which brings us to the recommendations regarding protein requirements. The target protein intake should be at the upper end of this SDI to promote optimal growth. So there is uncertainty. So limiting protein intake has had quite some attention, especially in the adult nephrology world, where it was theorized to limit GFR decline, and multiple very large-scale studies have been performed in adults. And there have been a few studies too of protein restriction in children. And there's one meta-analysis in the Cochrane database that found that there is uncertainty over the possibility of harm associated with the provision of strict low-protein diets on growth in young infants. So this is one figure from that publication of 2007, which showed that there was, regarding the outcome of height, there are multiple outcomes studies in this article, that there was no benefit or harm from protein restriction. But other publications have found associations between limited or restricted protein intakes and the increased risk of malnutrition, protein energy wasting, and poor growth. And so the lowest end of the SDI range of protein intake is considered the minimum safe amount of protein intake, and it should not be reduced below that level. It has been shown that growth can be attained with very low protein intakes, but should not decrease below that level. And when intakes of protein are above suggested dietary intake, then one should address that, especially when there are, in the case of high urea levels, high phosphate levels, and disturbances of the acid-base balance. When children are on dialysis, they will lose protein due to the dialysis treatment. In PD, the protein losses are quite significant, and given the fact that the peritoneal cavity surface is much bigger on a relative scale in infants than in adolescents, the losses of protein will be higher in infants on peritoneal dialysis, and which will have to be corrected in the diet and the protein intake. With regards to hemodialysis, there are no studies in children with respect to protein losses due to hemodialysis, and so these are figures from adults, and but the protein losses in hemodialysis should be taken into account with patients on hemodialysis too. In children with persistently high blood urea levels, protein intake may be adjusted towards the lower end of the SDI after excluding other causes of high blood urea levels. For instance, excessive dietary protein intake, but also catabolic state, dehydration, and steroid therapy will lead to higher urea levels. And all these factors must be taken into account when prescribing protein intake to children with CKD. So how can the nutritional prescription for energy and protein be provided to children? In infants, the World Health Organization is clear. Children should be fed with exclusive breastfeeding until the age of 6 months. When breastfeeding is not possible or expressed breast milk is not available in adequate amounts for the infant with CKD, we suggest a whey-dominant infant formula be used. And the reason for this is that whey-dominant infant formulas, as opposed to casein-dominant infant formulas, have a profile that is similar to that of breast milk with regard to protein and electrolyte. There is a suggestion not to use soya-based formula unless for a specific reason, and the reason to avoid these formulas is because of the high phytoestrogen content. To deliver the nutritional prescription, one can fortify the breast milk or the infant formula when there is a fluid restriction or when more energy or nutrient-dense feed is required to meet nutritional requirements. And apart from a fluid restriction, vomiting or gastroesophageal disease can also cause a need for restricting volume. The concentration of feeds and addition of dietary supplements prescribed should be described in a gradual manner in order to maximize acceptance and tolerance. More details about the administration and prescription of nutrition will be addressed further in this webinar. Solid foods should be introduced as recommended for healthy infants, with a progression to varied textures and content according to the infant's cues and oral motor skills. Delayed exposure to pureed and textured food may cause feeding problems. And a healthy and balanced diet with a wide variety of food choices should be the goal of every dietary prescription. Unfortunately, in the CKD study, a study of 658 children with mild to moderate CKD in North America between the ages of 2 and 8 years found that fast food was a major contributor of sodium, phosphate, energy, and fat. And when prescribing both formula feeds and regular diet, prescribing a formula that is low in potassium and phosphate might enable the child to enjoy other textured and varied foodstuffs for the learning regular feeding skills. As you know, oral feeding in children with CKD is a challenge. And so one should aim for pleasant and enjoyable oral stimulation in these patients, even if oral intake is limited, to prevent the development of food aversion. And the risk of food aversion, especially in the younger infants with CKD, is high. Tube feeding has been associated with chewing and swallowing problems, food refusal, panic attacks, and poor development of oral motor skills. And a more liberal oral intake may encourage more normal development and behaviors around food. And to support the patient and his or her parents, one should apply a whole team of specialists involved to stimulate normal feeding motor skills in children. So these would involve a speech and a language therapist, psychologist, a family therapist, and it would entail self-feeding and no force feeding, messy play and preparing food, or sitting at the table where other are having their meals. So to positive oral experiences like touching and kissing the cheeks and licking and tasting of food. Once deterioration in the weight centile is noted, prompt intervention is mandatory. And the first intervention should be oral nutritional supplementation, especially when intake is inadequate, after consideration of medical management of correctable causes of reduced intake. Medical management will involve treatment of gastroesophageal reflux, acidosis, volume overload, and inadequate dialysis. And inadequate intake is a risk in children with CKD due to reduced appetite, altered smell and taste, and abnormal hormone regulation. Enteral tube feeding should be considered and should be applied in children who are unable to meet their nutritional requirements orally in order to improve their nutritional status. And data regarding this recommendation are mostly from younger children, that is children younger than 2 years of age, and has been described in various retrospective studies that have shown improvement of weight or BMI standard deviation following initiation of tube feeding, and several of them have also shown improvement in height standard deviation. There's very limited evidence in children older than 2 years of age, but there's one study from Sarah Lederman from Great Ormond Street showing an increase in weight and height standard deviation in 2 to 5 year olds. Other studies have found no association between tube feeding and growth. And with these recommendations, I come to the end of my talk. We have formulated several research recommendations regarding protein and energy requirements in children with CKD. And these are mentioned here below. And now I will hand over back again to Roxana Schroff. Thank you for your attention.
Thank you very much, Michiel, and for an absolutely excellent and very, very thorough talk. So now it's my distinct pleasure to introduce Vanessa Shaw and then Nonnie Polderman. So Vanessa has been an honorary senior lecturer at University College London, Great Ormond Street, here in London, and she was the head of our dietetic service at Great Ormond Street for several years. She's been awarded a national honor, an MBE, for services to children's health care. Vanessa is a reviewer for pediatric nephrology and the Journal of Renal Nutrition, but much more importantly here, she's my co-chair and my right-hand person and everything else for me as part of the Nutrition Task Force. Vanessa served on many government committees and panels on child and maternal nutrition and advisory boards relating to this. She's absolutely committed to the education and training of dietitians around the world, has led a fantastic course through the British Dietetic Association, as well as through the VitaFlow webinars here. She's the editor of the Clinical Pediatric Dietetics textbook, which is the absolute go-to book for all of you here. Please do look this up and do get yourselves a copy. It's so worth it. Vanessa is going to do the next section along with Nonnie Polderman. So Nonnie, if we move the slides along, please. Nonnie is a very experienced dietitian from the other side of the world in Vancouver, Canada, and she has had over 20 years of experience as a pediatric renal dietitian. She's the author of several publications, including chapters in pediatric nephrology and case studies in pediatric dialysis. She's a member of the interdisciplinary team for the QI pathway, the quality improvement pathway at the British Columbia Children's Hospital, and also works with children with nephrotic syndrome in this regard. She's contributed to the Pediatric Renal Dietitians of North America Handbook, serves as a coordinator and a speaker at the Pediatric Renal Nutrition Academy, and is a member of the annual dialysis conference. In fact, more than a member, she leads the dietetic section of it now for many years. So with this, let's move on to the two experts in the field, Vanessa and Noni, and they're going to tell us more about the implementation of these guidelines. Once again, do keep contributing your questions into the question section. Thank you.
Thank you very much for that introduction, Roxana. We've developed a practical guide which elaborates on those clinical practice recommendation statements that you've just heard about from Nikhil. And what we're going to do for the next little while is to illustrate how you can apply this practical guide to your clinical practice by means of a case study. So Noni is going to interject at times to run through a case study which will illustrate how you can use the practical guide in your everyday practice. Now, the next few slides is just to show you how the guide is organized. So we want really to start with the questions that you should be asking yourself when you're seeing your patient, whether that's in the acute setting on the ward or whether it's in the outpatient clinic, and what you should consider. And then we have practical points throughout the guide which address these questions of consideration. So your first question to yourself is what are the energy requirements of this child? And this will involve considering an assessment of their growth, their intake, their nutritional status, seeing what the requirements are for optimal growth, and then doing the same for protein. What are their requirements for optimal growth? And do I need to take any modifications on board if they're on dialysis or if they're uremic? And then once we've determined energy and protein requirements, how do we give this nutritional prescription? Whether we're using breast milk, formulas, other fluids, or foods as the basis of the child's diet, we need to be able to provide a prescription that suits the individual child and something that is absolutely manageable for the family as well. So the guide starts off with a flow chart which summarizes the dietary management, and you can see that we've done this in easy steps so that you can work through this with this tool just on your desktop, so that you can see what are the steps are involved in producing your prescription. Don't worry if you can't read these slides, very small, but it's just to show you how we're going to go through a stepwise process, and we will go through these steps in much more detail as we go along. Okay, thanks, Noni. So we will integrate the practical guide into the case study. Now, the first step on the next slide, when you're seeing your patient, is to undertake a nutritional assessment. Now, we already have clinical practice recommendations which are purely devoted to nutritional assessment, and you can see the paper that I've put up on the screen there by Christine Nelms and the rest of the Nutrition Task Force. And there is a practical guide that accompanies this, which you'll find on the VitaFlow website. And also, as Roxana mentioned earlier, the recorded version of the webinar that we have on nutrition assessment is on the VitaFlow website, so you can look at that at your leisure. But essentially, there are three main elements to take into consider with a nutritional assessment. Firstly, anthropometry to measure the child's euvolemic weight, to measure their recumbent length if they're under 2, or their standing height if they're over 2 years of age. And if they're unable to stand, to remember that you can use recumbent length, or to use a proxy measurement for length if a child has, for example, contractures and you can't get an accurate length, in which case you can use tools such as demispan or ulnar length. And these are fully described in the nutritional assessment practical guide. And again, the third requirement that we would like for all children under 2 years of age is to have their head circumference measured. And you can do that up until 3 years of age if you've got validated charts that show the centiles for that purpose. And in addition, we think that it's useful to be able to plot weight for length for the under 2s and body mass index for the older children, plot these on the growth charts, and to use Z-scores as well to complement those growth chart plots. And again, details on that you'll find in the nutritional assessment guide. The key, though, is to plot serial measurements of any anthropometry that you do so that you can see the trend in a child's growth. And we recommend WHO growth standard charts for the under 2s because those charts use the data from the multi-center growth reference study, which you may remember looked at growth in a diverse group in 6 nations of children who were breastfed under ideal conditions. So those WHO charts for the under 2s show how children should be growing. For the over 2s, by all means carry on using WHO charts or use your country-specific charts. And those will vary according to the data set that's being used. And just to say that the WHO charts beyond 2 years of age are using very old United States data. So you may choose or not choose to use WHO charts. It may be better to use growth charts that you have specific for your country, which show better how your own populations grow. When it comes to dietary assessment, again, the techniques for doing this are described in more detail elsewhere. But if you want a very informative dietary assessment, then a 3-day diet history is recommended. But it may be sufficient just to do 24-hour diet recalls. So it's always useful to do a recall for more than 24 hours if you want a quick look at a child's intake. And the frequency of how often you do these diet histories or recalls will depend on the stage of CKD of the child, whether you have any particular nutritional concerns, what's the quality of their diet like, are their growth parameters abnormal, is their biochemistry out of kilter, do they have GI symptoms? So take all of that into consideration when considering how often you should do your dietary assessment. It's also a good idea just to ask about appetite, because that can be a very simple question to ask and can indicate if a child might be at nutritional risk. When it comes to biochemical assessment, the only evidence-based nutritional marker is NPCR measurements in teenagers on hemodialysis. There aren't any other nutritional markers, though often people will consider serum albumin as a nutritional marker. But actually, there are many reasons why a child might be hypoalbuminemic, which has nothing to do with their protein intake. So once you've excluded causes for hypoalbuminemia, such as inflammation, infection, or fluid overload, then perhaps you could consider serum albumin. Although these aren't nutritional markers, I'm sure we all do routine measurement of calcium, phosphate, potassium, and urea, and these may well inform your dietary management.
So for the purposes of this webinar, I'd like to introduce you to EB. She's a 2.5-year-old female with renal dysplasia. She comes to her first clinic appointment with very little information. But what we do know is that she's been tracking along the 3rd percentile up to her 2nd birthday, and then since then, both her weight and her length curves have flattened out. You've plotted the information you have at hand, and you determine that both the weight and the length Z-scores are worsening. While speaking to her mother, she provides a description of EB's typical day. So along with a small amount of oral solids, including some bread and butter, the majority of her intake is made up of infant formula mixed at a standard concentration. So together with the 800 mils of the infant formula and the small amounts of bread and butter, we estimate that the daily total calorie amount is about 640 calories. And if that's calculated based on her weight, it's equivalent to 63 calories per kilo per day. This combination of formula and solids provides approximately 1.3 grams of protein per kilo per day, which is equivalent to 8% of EB's total energy. Listed here are a single set of pertinent blood values that you have for EB. I've listed them both in millimoles and milligram units. And at this point, we know that she's demonstrating poor growth based on the current intake. And then looking at these labs, we know that some careful consideration needs to be taken to formula and food.
Okay, so our next step is to determine the energy requirements for this child. And I've just reproduced the table that you saw earlier. This is the table for infants. And just to remind you that we're only considering babies who are born at term, i.e. 37 weeks gestation. We're not considering preterm infants in this guideline. And Lonnie will be showing you in more detail the SDI for energy for older children when she goes through her case study. So we have three scenarios for determining energy requirements. The scenario of a child with suboptimal growth. And in this situation, then we would suggest adjusting the energy intake towards the higher end of the SDI range so that we can give maximum calories to promote linear growth and weight gain. The second scenario is if a child has normal growth, and as we heard before, the requirements for these children approximate that of healthy children of the same chronological age. The third scenario is if a child is overweight or obese, in which case we need to adjust the energy intake towards the lower end of the SDI range so that we can achieve appropriate weight gain or indeed perhaps weight loss in these children. But just taking into account that we need to preserve the nutritional adequacy of the diet, because inevitably if you're cutting down on the calorie intake, you may well be cutting down on protein and other nutrients as well. But we would like to suggest that we use the SDI to formulate nutrition prescriptions and to assess the adequacy of dietary intakes.
So back to our clinical application, we're going to use the SDI intake tables for energy, and we see that at 2 years of age, the SDI energies range is 79 to 93 calories per kilo per day. So using this range with our patient at approximately 10 kilos of body weight, she would require approximately 800 to 930 calories per day. But based on our food intake data that we were provided and that we analyzed, we're able to estimate an energy deficit of at least 160 or 16 calories per kilo per day at the low end. In our patient example, we could conclude that EB's growth pattern demonstrates suboptimal growth. And with the assessment, as Vanessa mentioned, of suboptimal growth, there may be indication to increase the energy prescription upwards. Table 5 of the clinical practice recommendation provides additional guidelines with regards to energy requirements for accelerated weight gain and catch-up growth. As you can see from this table, we may need to titrate energy as high as 126 calories per kilo to achieve some optimal growth. As part of Table 5, you will note guidance for optimal protein to energy ratio required for catch-up growth is listed as a range of 11 to 15%. More on the protein energy ratio later in the presentation.
So our next step, determining the protein requirements for this child. And again, here you can see that protein SDI is expressed as both grams per kilo per day and as an absolute value of grams per day. And again, we have three scenarios here. If we need to promote optimal growth, then we would be wanting to target protein intakes towards the upper end of the SDI. And just to remind you again that you heard earlier from Nikhil, that the protein intake at the lowest range of the SDI is the absolute minimum safe amount. Although a child may grow adequately on this minimum amount, and those minimum amounts are set by WHO in a document that they published in 2007, we don't want to drop the protein intake below that minimum safe level because we will absolutely inhibit any linear growth in that case. If the child is on dialysis, then we do need to account for those dialysis protein losses across the peritoneal membrane. And with the protein intake that should be increased, the values that you see there for PD and hemodialysis are agreement with those suggested by K-Doki. If a child has persistently high blood urea levels, then this may be an indication to adjust towards the lower end of the SDI. But first of all, do take into account if there are other reasons why the child may be running high blood urea levels, such as being catabolic, they may be dehydrated, they may be on steroid therapy. So take that into consideration before before beginning to cut protein, because essentially these children want to be as generous as possible with their protein intake, so that we can get some good lean tissue being laid down. We don't just want to be giving them lots of calories to make them fat.
So once again, using the SDI tables, we're going to look at protein. And for the age of 2, you're going to see that the SDI protein ranges from 0.9 to 1.5 grams of protein per kilo per day. So with EB at approximately 10 kilos of body weight, she's going to need just over 9 to approximately 10.5 grams of protein every day. So if we go back to that food intake data that we received from her mom and the analysis that we have done, we see that EB's protein was approximately 13 grams per day. So we know that she is meeting the SDI for protein. Of note, as Vanessa mentioned, with regards to additional protein for dialysis, we know that EB is currently not on dialysis, so we do not need to consider additional protein for that reason. Again, if we were to think about EB's growth as suboptimal, we may need to adjust that protein higher. As mentioned earlier, Table 5 in the CPR does address energy and protein requirements for weight gain and catch-up growth in malnourished infants and toddlers. And while these increased prescriptions for energy and protein may not necessarily be achievable for EB immediately, it does provide the clinician with some guidance regarding energy and protein amounts required for catch-up growth, and it may help frame the clinician's decision regarding the nutrition prescription going forward. And again, as with anything, any change that's made to the nutrition prescription, it is important that the patient's tolerance, the subsequent growth, and biochemistries are monitored carefully.
So here are practical tips to achieve the appropriate energy and protein intake. Just to remind you that we do recommend that we use the SDI for height age if the child is less than the 3rd centile for height. And also do just remember that children on PD will be absorbing glucose from the dialysate, and this can contribute as much as between 7 to 9 kilocalories per kilo per day, and that needs to be taken into account when prescribing the nutritional prescription for energy, because we're getting that extra exogenous energy from the dialysate. And while some children may benefit from having this additional dialysate energy, for other children, these extra calories can actually lead in the long term to excessive weight gain. So do always make sure that you're aware, if they're on PD, that they're getting that extra source of glucose and therefore extra calories, especially when we're considering that obesity is increasing in children with CKD. And we may need to start to think much more about modifying their energy intakes and their lifestyles, for example, their physical activity, to make sure that these children aren't gaining weight excessively. And these are some points about protein intake, that although we said that there are no nutritional markers specifically as to how much protein a child should have, we can use urea levels as an indicator if they're getting adequate protein, or indeed if they're getting too much protein. Just consider that we don't expect that children with CKD 2 to 5D will have the blood urea levels within the normal range. And indeed, if they're showing low urea levels, it may well be an indication that you're starving them of protein, that you've been too strict in denying them protein. And as I said before, we always want to be as generous as possible with their protein intake. If the child's urea levels are chronically running higher than you'd expect for their degree of CKD, it's most likely due to them eating or taking too much protein in their feed. But before cutting down protein, do check for other causes of elevated urea levels, such as catabolism. And again, just to remind you that extra protein will be needed if the child's on PD or hemodialysis. But we do need to take into account their peritoneal transport status, and just also to remember that they'll have increased protein requirements if they're in a stage of acute peritonitis. So just starting to look at oral fluid requirements. We're starting with oral fluids because obviously babies have a liquid diet, they're not eating food. As you heard that breastfeeding is, or express breast milk is preferred with a whey dominant infant formula as a suitable alternative. And again, we're giving you 3 scenarios here of a baby on a restricted fluid volume when formulas can be concentrated to meet their requirements in that lower volume of feed. If they're on a normal volume, then they can just have age-appropriate fluids. So for a baby, 150 mils per kilo as an average. And just remember, if a baby needs additional volume, if they're polyuric, for example, then additional fluids can be given just as water. Don't try, if their requirements to remain hydrated are, say, 200 mils per kilo, don't try and feed them 200 mils per kilo of formula. You'll simply be overfeeding them, and the child will respond probably just by vomiting of the feed that they're given. Give normal requirements, 150 mils per kilo, and give the additional fluids just as plain water, which a child who's polyuric will drink very readily because that polyuria will drive their thirst.
So back to our case example of EB, we have not seen any modifications made to her fluid prescription. So as a clinician, you're going to aim for age-appropriate maintenance fluids, which would be 100 mils per kilo or 1,000 mils per day in EB's case, which you see in the middle of the slide under normal volume. Again, as per the record of intake, we know that EB's daily intake is estimated at about 800 mils. So that would suggest she would have an additional 200 mils of water to drink. However, in the event that the fluid was restricted, final volumes of formulas as seen on your the left-hand side of the screen may need to be decreased. So if this was the case for EB and her formula was decreased from 800 mils of standard infant formula at 66 cals per 100 mils, and it was decreased down to 720 of a total volume, then the resulting concentration would increase to 75 cals per mil. Likewise, if the volume was decreased even further to 400 mils per day, the resulting concentration would be double, or 112 cals per 100 mils. For patients with additional volume requirements, formulas may need to be diluted with additional water. Alternately, you could provide additional water provided separately. However, in cases with increased volume, ensuring that nutritional requirements are met is paramount in order to optimize growth.
So we want to move on to solids. As we heard before, we try to adhere to WHO recommendation of exclusive breastfeeding until about 6 months of age. But of course, this may not always be suitable or appropriate for the baby with CKD. So as a general rule, introduce solids as for healthy children at around 6 months of age, so individualize the timing of this, and try to progress with varied tastes, textures, and content, and to aim for a balanced diet with a wide variety of foods. And again, for the older child of 1 year of age, we want to get them inured into a healthy, balanced diet as early as possible, because we heard that from the CKD study that children with CKD tend to have what we might consider unhealthy diets, high in sodium, high in phosphate, high in saturated fat, and far too much energy. But we'd also need to take into account that as the degree of renal failure deteriorates, there may be a necessity to limit the diet in certain nutrients, and it's usually potassium and phosphate and sometimes sodium. So we still need to make the diet nutritionally adequate, even if we're having to cut down on some foods because they contribute too much of these nutrients that are no longer desirable. So we'll always check against the child's biochemistry to guide us as to how far we need to make limitations on certain things like potassium and phosphate. I won't go through this in much detail because you heard about it from Nikhil, but we've got here some practical some practical points about how to encourage an oral diet in these children who are very reluctant on the whole to eat. And we do provide in an appendix of the practical guide some of the barriers to not achieving an adequate oral intake. And the key things, again, I put on the left-hand side of the slide, are to allow the child to self-feed so that they're not feeling under pressure, that there's no force feeding. The child's allowed to indulge in messy play so they can get their hands in the bowl of food, they can smear it over their faces, put it through their hair, throw it on the floor, so that they can see that food isn't something threatening that they've just got to get down their throat. For older children, get them involved with preparing food and sitting up at the table at meal times, even if they don't eat anything or only have a few mouthfuls of food. And positive oral experiences from a very early age, like stimulating around the mouth area, allowing them to lick food, tasting food without any need to actually swallow them, will all help to promote normal behaviour around food. Just to say one thing from this list, it may be useful to continue with infant formula beyond 1 year of age because it's a very useful source of vitamins and minerals, and it's low in phosphate and potassium. And in some countries, we have toddler milks or young child formulas, and these are commercially available milk drinks for older babies from 1 year onwards. And again, they're a useful source of vitamins and minerals, and maybe a useful supplement to the diet of a child who's eating very little food. Once there starts to be a drop in weight centile noted, then it's very important to start oral supplements to get that nutritional adequacy back. And there are 3 things that we can do here. We can fortify foods, we can fortify drinks, and we can offer oral nutritional supplements.
So back to our clinical application, we know that concentrating or fortifying feeds provides a way to increase calories of a standard infant formula. And so you'll note in Table 2 of the clinical practice recommendation, and you'll find it in the practice guide as well, a standard infant formula prepared using powder at a concentration of 20% or 20 grams per 100 mils will provide 103 calories per 100 mils. Similarly, if you want to fortify express breast milk, you're going to be adding an extra 6 grams of infant formula powder to each 100 mils of breast milk. It's important, though, to note that as energy is added to either of these feeds, the amounts of protein and other nutrients is also increased. So if in EB's case, additional volumes of infant formula at standard concentration cannot be achieved, then concentrating current volumes may need to be considered. In each of these examples, concentrating the volumes of infant formula and EBM bring the total calories into the estimated range for EB that we've estimated she's going to need to achieve some catch-up growth. Do note that as formula is concentrated and express breast milk is fortified, there are corresponding increases in macronutrients. However, this does not impact the protein-energy ratio. So Table 4 of the Energy and Protein Clinical Practice Recommendation, which is also found in the practice guide, provides information regarding macronutrient contributions of modulars. So this would include your protein powder, fat emulsions, and glucose polymers. In our case with EB, it is only once you've added some additional protein using protein modular that you are going to impact the protein energy ratio and have it approach 11%. As noted earlier, the optimal protein energy ratio for ketchup may be more in the range of 11 to 15%. Fortifying and concentrating formulas to achieve energy and protein goals requires careful consideration with respect to additional nutrients such as electrolytes, vitamins, and minerals. So for this reason, the use of additional infant formula powders may meet your energy and protein goals, but you may actually find that the formula results are one with excessive potassium, phosphate, or vitamin concentration. So it's really important that the clinician take into account the resulting increases in all aspects of the feed in order to assess whether it's going to meet the clinical needs of the child. Table 6, which is found in both the CPR and the practice guide shown here, provides a stepwise guide to the addition of energy to feeds using both glucose and fat emulsions. Modulars such as glucose polymers and fat emulsions should be added or titrated gradually, and definitely be watching the child's corresponding tolerance. Table 6 provides age-related guidance to modulars. However, your individual practice and your jurisdiction is very likely going to control the availability and determine what products you have available to you. In EB's case, she's 2.5 years old. The final concentration of glucose would be made up of both the formula as well as the added polymer, and we'd be looking at a guide of 20 to 23 grams of carbohydrate per 100 mils of feed, and then adding additional fat as a fat emulsion to a formula for a child greater than a year of age, we'd be looking at a final concentration that does not exceed 9 grams per 100 mils. So let's look at adding modular products to a standard infant formula, one that, such as the one EB is consuming. So possible options for meeting energy and protein needs without increasing the volumes of that original 800 mils would require adding protein as powder along with glucose polymers and some additional fat to get the calories up to around 800 or 80 calories per kilo. So this composition would also meet that optimal protein energy ratio as 11%. Do note that if you have additional water being added to this formula, it would not change the nutrient composition. The only thing that additional water would change is the concentration.
Okay, so the next couple of slides, again, are going to be quite a small font, so you won't be able to read them very well, but it's just to show you what's in the guide. When we're fortifying foods, we've given a list in Table 7 of high energy foods with a low protein content that might be useful additions to the diet. So we could have the next slide, please. You may be filled with shock and horror that these are largely based on refined carbohydrates and fats, and you may prefer to give a complex carbohydrate diet with more fiber and nutrients in it. But I think you'll all agree that with some children with such poor appetites, the most important thing is to get adequate energy into them. And if we have to rely on foods which might be considered slightly on the junk side, it's better that they eat those foods than eat nothing at all. So these are some examples of high energy, low protein foods which can be used pretty much ad lib. In case you do need to start restricting protein, we've given protein portions here for high biological value animal-based foods and the lower biological value-based plant foods. And each of these portions provides 7 grams of protein, so it will help you to construct a diet where you can swap in these different amounts of protein. Next slide. And here again is a table to give you some tips on how to add extra energy to foods and drinks by using glucose polymer powders or using a mixture of glucose and fat powders, which are available commercially. How to use simple sugars like table sugar, jam, honey, etc. How to add fats to food, and also the quantities of the glucose polymer powders that you can add to drinks. In addition to you just using fat and carbohydrate, you may be able to offer SIP feeds or oral nutritional supplements, which again, if the child will drink them, they come in a variety of flavors, will provide a good source of energy and protein and a good range of vitamins and minerals. There is a pediatric renal specific ONS available. If you have only got adult products available, do just be aware that they may give excessive amounts of some minerals and vitamins, and you might need to modify them. It may be useful to use plant-based milks as a source of energy, and they will be low in phosphate as long as they haven't been supplemented with calcium phosphate, because most plant milks now have this additional source of calcium added to make them more suitable nutritionally for healthy children. And again, you may have in your countries protein-free milk replacement drinks, which are all good sources of energy, to improve the energy content in these children's diets. But what's key whenever you make any change to a child's diet is that you go through this cycle of monitoring, assessing and reviewing, so that you're constantly looking at their growth parameters, you're looking at their dietary intake, you're looking at any limitations that you may have imposed on them because of their biochemistry levels, always checking against their nutritional requirements to see whether you need to improve their nutrition or indeed cut back on certain nutrients. Have a look at the barriers for achieving adequate oral intake, whether it's poor appetite or gastroesophageal reflux, and also take into account their activity level, because that's going to have an impact on how much energy they need, and if there are any intervening medical managements that are necessary or might be affecting their diet. But to improve nutritional status and to promote their growth, we do need to think about supplementing not just orally, but to start on some enteral tube feeding in children who can't achieve their nutritional requirements by mouth.
So back to our clinical application, EB comes to her follow-up appointment, and it's determined that she is unable to achieve the necessary volumes to meet her energy and protein requirements. She's not progressing with normal developmental milestones with regards to self-feeding or taking any solids, and she's been demonstrating some food refusal behavior. Her repeat anthropometric measures are not improving. It does appear that the clinician's attempts to modifying feeds is not resulting in the improvement in growth parameters that we were looking for.
So our last stage, and we won't go into this in any detail because we have yet another published paper on this topic. If we can't get adequate nutrition into the child with oral supplementation, then we need to look at providing that nutrition through tube feeding. And for short-term tube feeding, we are suggesting the placement of a nasogastric tube. But for longer-term delivery of extra nutrition support, then we would definitely promote gastrostomy feeding. And we will be presenting this clinical practice recommendation paper in a later VitaFlow webinar, so we won't go into that now. But I think we are ready for any questions that you would like to pose us.
Thank you very much, Vanessa and Noni. That was a fantastic and very, very useful practical run through. So let's come to some questions and answers. I know we are slightly running over time, but we've got a whole bunch of really good questions. And I can see that these come from practicing dietitians around the world. So that is fantastic. That is a great tribute to our task force and to the wonderful talks you've done. So without further ado, Michiel, first question for you, please. With these recommendations we have for chronic kidney disease, are they applicable to children with AKI and to those on CRRT?
Applicable to children with AKI, no. They have been developed with the eye on children with CKD, stages 2 to 5, and children on dialysis, so stage 5D. So yes, children on dialysis, but not on CRRT. We are currently developing a guideline for children with AKI. I must say the yield in the literature search is quite poor, but we hope to at least come with some recommendations, guidelines for children with AKI with or without renal replacement therapy.
Thank you, Michiel. That's absolutely right. That's the guideline we're working on now. Thank you. So a question for you, please, Noni. And this is becoming an increasingly topical issue. Could you comment on vegetarian CKD infants and the risk of soya-based formula intake?
So yes, you're correct, Rakshana, that vegetarian and choices around possible vegetarian sourced products is definitely something that we see more and more requests about. I think that any dietitian with families that are asking about vegetarian-based products is going to want to do a very careful consideration of the nutrient profiles of the products that they are or they're prescribing. And as mentioned in the practice guidelines, we generally are not recommending soy-based formulas. Vanessa, would you like to add to that?
Yes, I think it's very important if a mum does want to give a vegetarian diet to her infant, that she's strongly recommended to breastfeed her baby, or if for whatever reason the baby can't be breastfed, she expresses her breast milk. And it's particularly infants under 6 months of age who are going to be most vulnerable to the phytoestrogen content of soy infant formulas. The amount of soy in solids is not such an issue. It's when it's a sole source of nutrition that the dose of phytoestrogens that you get from a soy infant formula is high per kilo body weight for the young infant.
Thank you both. Michaela, a question for you, please. We have, and I must first announce to the audience that we do not recommend the use of BUN, blood urea nitrogen levels, in your routine assessment. But Michaela, could you comment, please, on what you would consider low versus persistently high levels of BUN in your assessment?
Well, first, I would find it hard to convert the BUN to urea, as BUN is a commonly unit that's used in the United States. I know the conversion factor is somewhere 12.5 or something. Yeah, and but too high for me would be above 30-35 urea millimoles per liter, and too low for a child in end-stage renal disease, end-stage renal failure, would be below 15. Below 20 would point me in the direction of very low or inadequate protein intakes. But I'm happy to hear other opinions, because there is no guideline regarding to this.
It was certainly.
Sorry, Roxana, we did talk around the table in the task force about whether we could define acceptable urea levels. But amongst the experts around the table, we all had a different idea, and there's no evidence to support what we were saying. So although we all have our own personal practice, we might say we want to keep urea levels below 15 in a young infant, but not below 5, say, if that's just our own personal practice, and there's nothing to support it at all.
Absolutely right. That it is affected by so many different factors as well. Completely agree. And in fact, a very low urea or BUN might suggest undernutrition, which is an equally important factor. Vanessa, if I may come with a question to you, please. Protein energy ratios. Can you tell us a little bit about this? Do you follow it in your practice, and where do you like to keep it?
Well, first of all, those protein energy ratios are derived from WHO work on malnourished, if we could call them healthy children, in that they're malnourished and that they don't have any underlying disorder. So we don't really know what the ideal protein energy ratio is for children with CKD. We're simply extrapolating from WHO data for malnourished children. And they have shown from their protein energy balance studies that the protein ratio should be between 7 and 12%. For adequate weight gain. Now, for me, one of the key research projects that I hope might spin out of this work that we're doing is looking at what the ideal energy protein ratio is for the child with CKD, because I think there may be a tendency to reduce protein in these children's diet because they're uremic. If running a high urea level isn't symptomatic and it isn't doing them any harm, perhaps we do accept that we run high urea levels, and because that's the result of giving them more protein. And for me, we need to be generous with the protein intake so that we can get laying down of lean tissue, because we know these have muscle mass, we know that they have central adiposity. By giving them high calorie diets without sufficient protein, are we just exacerbating that pre-existing cardiovascular future that they have ahead of them? So for me, it would be a very important piece of work to see if we could fix an ideal protein energy ratio for the child with CKD. And my feeling is that we will be working towards a higher protein energy ratio so that we can get good quality growth.
Okay, thank you so much. Now, we have just a few more minutes left and a whole bunch of very practical questions. So Vanessa and Noni, a bit of a rapid fire session, quick answers if possible. Noni, would you add honey to food as a source of energy?
You could. I would recommend pasteurized honey.
Thank you. Vanessa, how do you prevent vitamin A toxicity in your patients?
We can't. We would like to give them as little vitamin A as possible, but with the current formulation of infant formulas, we're always giving too much vitamin A. We need a new brand of infant formula for children with babies with CKD that is low in vitamin A.
Indeed, thank you. Noni, would you? What's the maximum concentration of infant formula you allow? Is it 20%?
20% would be equivalent to 1 calorie per mil, and that you could actually go higher than that. A little later on, you could move towards 2 calorie per mil, but not necessarily in the infants. Our case study was sort of a hybrid infant toddler, so I think we had some room to move on the concentration in her case.
Thank you. Vanessa, is it better to quote energy requirements per kilo body weight for all ages?
Certainly for babies infants up until 2 years of age. I think beyond that, it tends to be a complete figure, if you like, the calorie intake for the whole day rather than per kilo.
Thank you. Noni, what are your views on feed thickeners in babies who vomit?
I personally don't use a lot of them in my practice, so I'm probably not the best one to comment on it. I personally don't use a lot of them.
Vanessa, may I ask any practical tips on that?
I absolutely agree, because the vomiting in babies with CKD isn't an anatomical issue like simple gastroesophageal reflux. It's absolutely controlled by the hormonal milieu of not having kidneys that work properly. So thickening feeds isn't necessarily going to stop the GOR. It's more the hormonal influences which cause that gastroesophageal reflux.
Thank you. Next question, perhaps Mikhil, if you could help us with this. So this question comes from an expert in infant dialysis who asks that in an infant who's very well dialyzed, you may have hypophosphatemia. And what are your recommendations for preventing this?
Well, no restrictions on the diet. Stopping obviously phosphate binders if the patient's still on the phosphate binders, and if despite these dietary measures the phosphate remains low, you should add phosphate to the dialysate if possible. It might be hard to obtain a clean sterilized phosphate supplementation to be added to the dialysate, but I guess that's the only solution if you don't manage with nutritional dietary measures.
Yes, indeed. Thank you. And perhaps even using alpha calcidol to increase phosphate absorption, yeah? Perhaps. Vanessa, amino acid supplementation for from PD fluid, is that good or bad?
It's something that I've never done in my practice, so I can't. I'm afraid I can't answer that one. I don't know if Mikhil has personal experience.
I have no experience with it.
No, and indeed, we don't use that in our center either. And in fact, there is a concern that the more things you add to PD fluid, the greater the risk of causing some sort of hypersensitivity reaction in the peritoneum, including causing an allergic response with and eventually leading to peritoneal fibrosis. So I would not recommend that. Absolutely. Okay, so we are just 1 minute over, and many of the subsequent questions ask about, first of all, thank you all for the excellent talks you've done. So a lot of comments are thank yous and very well done. Some questions ask about recordings, and yes, these will be available. Some questions ask about the SDI in more detail and providing the SDI chart. And again, this is available in the practical practical management and dissemination material we have. So I'm going to hand over to Lucy for the last couple of slides and to wrap up. But from my side, thank you to all the three speakers. That was fantastic. Lucy, over to you.
Thank you, Rukhsana. So just to close, again, another big thank you to the speakers for taking the time to present to us today and just showing really how we can put the clinical practice recommendation information into practice. So as mentioned at the start of the presentation, this webinar forms part of a series by the task force. So this slide highlights the 2021 webinar schedule. Each webinar will cover a specific area of dietary management of paediatric kidney disease, and we'll discuss the published clinical practice recommendation and the practical application of them. The next webinar by the task force will be on the topic of the dietary management of calcium and phosphate in children with CKD 2 to 5 and on dialysis. This webinar will be held on the 11th of June, so look out for the invite, which will be sent to you all soon. So to conclude, on behalf of VitaFlow, we would like to thank you for tuning in today. Please do take the time to complete the evaluation questions because this is really useful for us for future sessions that we do. Please download your certificate of attendance as well. Thank you for your time today and please enjoy the rest of your day. Goodbye, everyone.
Thank you all. Bye-bye.
Bye-bye.